Thank you for choosing Axxess On Demand. Axxess believes in continuing education, and we create content to empower you to learn and grow anytime, anywhere. Let's get started.
Hello, thank you so much for joining us for this live webinar to discuss how Axxess Care can help your emergency preparedness and response with the outbreak of the coronavirus or COVID-19. My name is Laura Barnett, and I'm on the marketing team at Axxess. Before we get started, I'd like to tell you a little bit about Axxess. We're a leading home healthcare technology company offering a complete suite of easy-to-use, innovative software solutions that empowers home health, home care, and hospice providers to grow their business while making lives better. I'm looking forward to today's presentation. It is very timely, and today you'll hear from my friend and colleague, Tammy Ross. Tammy leads Axxess's professional services team. She has 30 years of experience in home healthcare and is a sought-after thought leader with operational and clinical excellence in her toolkit. Joining her is Rachel Hammond, the Executive Director of the Home Care and Hospice. Rachel works to ensure the daily operations and strategic direction of the association and to ensure that that represents the membership of the association. Before we get started, I'd like to share a couple of housekeeping items. Everyone's phones are currently muted. However, you may submit questions throughout the duration of the webinar. If time permits, Tammy and Rachel will answer as many questions as we can get to at the end. And if we don't have time to answer your particular question, I promise you we will follow up with you after. Following the webinar, we will provide everyone with a link to the slides, and we'll also post a video recording of the webinar on our website at axxess.com. Ladies, without further ado, take it away.
Thank you, Laura. We'll get started here and start with our objectives and what we're going to be reviewing in this session. So today we're going to look at the exploring the changes of the workforce landscape. We'll talk about the different demographics that are happening. You've heard it called the silver tsunami, the silver tide, gray of healthcare, and how that is really pushing an already stressed environment. We'll also look at the demographics of the nursing workforce and explore skill sets that's needed with clinicians under PDGM and, of course, now under our emergency preparedness and COVID-19. And then we'll talk about how technology can assist you for not just scheduling and staffing, but how it's imperative that you're using technology now to help you implement your emergency preparedness plan. Just to say how fast things changed, last week, Monday, when we were looking at this presentation, COVID-19 was not really being thought about to the extent that it is now here in Texas. We were really just going to focus on PDGM and scheduling and staffing, and in less than a week, that completely turned around. So I'm so grateful to have Rachel here with us today. She's going to be able to give us a lot of insight about what's going on in Texas and with our nursing force and what our association is doing to help prepare us for emergency preparedness and for this pandemic. So as we talk through this, some of the slides might not exactly match up as we add in COVID-19 information, but we did want you to have the most up-to-date information possible. And I'm going to turn it over to Rachel to kind of start talking about that growing healthcare demand and what's causing that.
Well, thank you very much. Obviously, home care is in a unique position right now to be helpful and to really step into mitigating the spread of COVID-19. But even before, this was kind of at the forefront of our minds on a regular basis. We knew and have known for some time that the need for home care is going to increase and increase exponentially over time. So what that does is it puts home care agencies really right there at the forefront as kind of the solution for healthcare. So as we think about that, that puts a lot of regulatory strain on agencies, particularly during this time, agencies should be implementing their emergency preparedness plan. And as we have seen during this changing pandemic, it's put a lot of stress on agencies and their ability to effectively staff the census that they have, and then also deal with any oncoming or incoming patients, and then with the staff that they have. And so how do they handle that from a regulatory standpoint? Before this pandemic, obviously, it was very important to ensure that you could handle your census at any point in time, and your disaster preparedness plan was there and in place to help during times of disaster. And part of that is to address staffing challenges, and we're seeing that quite a bit right now. It's kind of a trickle-down effect with that has been going on as it relates to supply shortages. So when you have supply shortages, it's hard to send people into homes that might have some presumptive positives in that home if you don't have the appropriate PPE to do so. You might also be experiencing supply shortages as it relates to individuals who have children at home and no way to have childcare in place while out doing visits, or supply shortages because maybe they're self-quarantining because they might feel that they've been exposed. So there's a number of issues that agencies are facing right now, not only related to what we have seen coming as it relates to the silver tsunami, so to speak, but what we're currently experiencing and the growing demand for our services.
Thank you, Rachel. And I think as we look at the stress environment and we look at the fact that our senior population is doubling, and we see that looking at aging is exponential over the next 30 years especially, but even over the next 10 years, we're seeing the fact that demand for nursing staff, even outside the pandemic, is going to be huge. And as this landscape starts to need more nurses, as the working demographics, we start to need more healthcare professionals. I wanted to just share a slide for projections. And as we look at that, we see that orderlies, personal care service workers, home health aides, nursing assistants, personal aides, and registered nurses is going to grow at the most rapid rate of any organization or any particular career field. And honestly, the supply is just not keeping up with the demand. And then we can see here, as we're looking at another slide from our U.S. labor statistics, that our nurses and personal care aides and nurses assistants, again, the new jobs and the replacement jobs, as we look at that graph, the blue representing new jobs and the green representing replacement jobs, we can see that we're going to almost double what we need in replacement jobs as we look over the next few years. Rachel, I think you're right on target with the fact that, in home care now, we're needing more and more staff. What are you hearing from different organizations about that and about staffing right now?
Well, I mean, certainly it's a challenge. What we are hearing more and more often is that our ability to hire staff, particularly registered nurses, is complicated by the fact that we're in competition with other healthcare organizations, particularly hospitals. What makes it very difficult for hiring are some of the stressors that our industry presents. Many, I think you're going to address this a little bit later. There's a lot of paperwork in home care. There's a lot of regulations in home care that make it not necessarily as attractive. And then we also have the reimbursement challenges that we've been experiencing over time, both in the Medicare and the Medicaid space. Home care in particular is fairly vulnerable to that because the primary payer sources are Medicare and Medicaid. And as we know, it's been particularly volatile in the Medicare and the Medicaid space. So our ability to be competitive, particularly for professional nurses, is quite difficult. The economy also has had a significant impact on our ability to hire personal care attendants or home health aides. Because we've had a very good economy, it makes it a challenge for those folks as well when you have for instance, the oil industry, that have had some significant peaks and then experiencing some down. It makes hiring those individuals difficult. Likewise, when the economy is doing well, other industries pay more. So there's just a number of challenges. And so as the association, what we're doing to really proactively address this is in all of our advocacy, both at the state and the federal level. Workforce is a huge issue when we're talking about the reimbursement for Medicare and Medicaid, and incorporating those principles into our overall reimbursement methodologies. So it's really important that the government understand that part of our ability to provide the quality services are ensuring that we have the appropriate workforce in place as well. So, we're working with the National Association on a huge workforce summit in particular related to the personal care attendants, because we are going to see a major shortage for personal care attendants at all levels of home care and hospice. And then likewise, as it relates to nurses, we work both at the state and the federal level. I'm on the Nurse Practice Advisory Committee with the Texas Board of Nursing. Workforce is a topic of conversation, as well, again, at the federal level, as we look at our reimbursement methodology, ensuring that it's substantial enough to address our workforce needs.
Yeah, Rachel, and I think if we look at declining occupation projections, again, from the U.S. Labor Board of Statistics, we can see that there's a lot of occupations that's going to decline significantly over the next few years. And some of these may have very good crossover skills for those personal attendants, such as human resource assistants, hotel and motel desk clerks, tellers, postal service workers. These are people that are already used to dealing with customer service, listening to their clients, which is a good bit of personal attendant services. And certainly I know there's other skills that are involved. We certainly have to look at some of those healthcare skills, like assisting them with ADLs. And as we look at PDGM and kind of put this in perspective of PDGM as well, it's so important that we do more with less expensive resources, that we utilize our resources efficiently. So these personal care aides and CNAs, I think, is a great way to utilize this lower paid skill set to deliver excellent outcomes for our patients. And honestly, I started my career as a CNA many years ago in a nursing home, and I can tell you that CNAs deserve a ton of respect. Our patients love them. Our staff love them. They're the ones that's in the know. They often know things that nurses and therapists don't. So we really need to start looking at how to include them and how to actually broaden the base of CNA and as far as the healthcare fields for home health and hospice. And just one other thing I'd like to mention about this change in workforce demographics. We're starting to see a bigger percentage of our workforce move into the millennial area. About 35% of our workforce are millennials now. That really changes the way care is delivered and the way they want to work. Millennials want to be in touch constantly. They're very good with technology. They like to have flexibility. And all of this pairs excellently with home care and hospice. These are career fields where you can do 2 days a week or 3 days a week, or maybe just see visits in the afternoon, or maybe just see visits in the morning. So as we start thinking about that, starting to think about how we're going to start training the millennial workforce for the home care and hospice workspace. Rachel, anything else on staffing before we kind of jump into some more details on PDGM and COVID-19?
Not too much more, just, obviously, with the current pandemic, we have received some phone calls from different agencies really letting us know that right now, obviously, as we see other businesses kind of shutting down in response to the administration's guidance in terms of prohibiting large gatherings and requiring businesses to shut down, home care agencies are operating in full force, obviously. We are healthcare providers. We are on the front lines of providing care and services during this particular time. So as the association, we're putting out information particularly as it relates to RNs, and I think we'll get to this in another slide, and using RNs or using nurses from across state lines. Then also, you'll see on some of our social media today, a reminder about our career center. Right now, as agencies are looking at how do I meet the staffing needs and ensure that people to see clients in their homes, and they're feeling the pinch a little bit with their staffing. We do have a career center that is available to our members for free. They can post for free for 30 days on that career center. We're going to get that information out there and remind people that it is there. And there are people right now, in other industries, as you mentioned, that are, or could be available to meet the surge capacity needs that we have in home care. So that's something I can detail a little bit later in the other slides, but that's really all I have to say.
Thank you, Rachel. No, that's excellent information. Thank you. And certainly we thought PDGM was rough, and that created a lot of challenges on healthcare. I think we had just started getting our legs back under us as an industry, and now we're hit with COVID-19. So additional challenges are being added to our already stressed workforce. So we really have to start thinking outside the box with how we're going to meet the needs of our patients. And I think everybody knows about COVID-19. There's been lots of information about it, but I do just want to take this opportunity to let our audience know the symptoms of COVID-19 being a cough, a temperature of 100.5 or greater, shortness of breath, sore throat. It is spread by droplets. We've been getting a lot of questions, is it airborne or is it droplets? It is spread by droplets. By coughing or sneezing. And right now there's no treatment for COVID-19. And basically the treatment is based on your symptoms. So we're treating symptoms, not the actual virus itself. There's plenty of resources for COVID-19. TAC has resources, Axxess has resources. We'll show you those here in a moment, but certainly familiarize yourself. And things are changing, not just daily for COVID-19. We're getting information sometimes hourly, new information about COVID-19. There's new things coming out from DC, from legislation, from public policy. And Axxess will be doing a public policy briefing next week, a webinar, and I would encourage you to sign up for that, which will be telling you all the newest legislation surrounding COVID-19. Certainly, as Rachel mentioned, we're dealing with a workforce that also has limited supplies. I have 2 daughters, both of them are nurses, and just prior to this webinar, one of them actually that works in home care came over to get a stack of masks and gloves from me because their agency hasn't been able to get them. people are starting to hoard supplies. So, you know, we're asking certainly people to cooperate, not lay people, you know, not to hoard the supplies. Our professionals need them, especially our professionals going in and out of homes. We're also stressing social distancing. We're starting to see some restricted access to patients. So how are we managing these patients inside ALFs, memory cares, making sure that we can still address those outcomes when maybe they're not allowing us to come into the facility anymore. I know of people in memory cares and ALF in any therapy related or non-essential care, and basically non-essential for a lot of these facilities is wound care only. They're not allowing staff in. So how are we going to manage that and manage our outcomes? And certainly, you know, we want to also look at financial considerations. This is going to lead to multiple missed visits, which is going to lead to lupus and obviously decreased reimbursements for agencies. Our association, including NOC and TAC, you know, they're lobbying for us, and I know Rachel will encourage you at the end of this to really get involved with your association. If you haven't been involved, now's the time to do it. We need the government to listen to us now and to understand during this pandemic, we need to look at some changing rules and some changing legislation around lupus, around telehealth, allowing telehealth to actually count as a visit. So we'll leave that to the summary and kind of let Rachel talk about that. But here's actually the resource page for Texas Association of Home Care and Hospice. And Rachel, anything else you want to say about this resource page?
Yeah, I'd actually like to address a few things that you talked about from a regulatory perspective. One here is that's kind of what the front-facing resource page looks like. We have information on the latest guidance and preparedness. All of the information that we post are from credible sources, be it the CDC, the WHO. There are some pieces of information that we have received from experts such as Barbara Citarella, you know, that is our home care and hospice checklist that might be very helpful for your emergency preparedness plan. There's also educational materials that you can use to educate your staff. There's guidance on what all providers should be doing prior to every visit when they go out to patients' homes right now. That guidance is being utilized by your state agency, HHS. We are in frequent communication with both your state agency, HHS, and with CMS and Palmetto. On the state side, we had a call yesterday with HHS related to regulatory relief from a survey perspective. We anticipate that we will see some emergency rules come on board by Friday and some additional guidance for agencies, hopefully by Friday. We're working with them to do a webinar to go over those rules for providers, either Friday or Monday. At this point, it will probably be Monday so that we can get as many folks on the phone as possible to go over what those emergency rules mean for you and some policy guidance. In addition, we've been working with CMS quite heavily to get some regulatory relief. You know, as you heard Tammy say, we're trying to get some relief on some of the COPs and some use of telehealth and telemedicine. Although they are trying very hard to get that information out and get it out quickly, it's not necessarily been crystal clear, and in some cases created more questions than answers. Right now on the Medicare side, physicians can conduct visits, particularly the face-to-face visits, using telemedicine technologies or telehealth technologies. But that does not relieve your responsibility as an agency to obtain that documentation of that visit. So regardless the face-to-face visit, you will have to, of how that face-to-face visit is conducted by the physician, you will have to maintain or receive that documentation from the physician as you ordinarily would. The flexibility comes on the physician's side on how they conduct that visit. On the state side, we are working with HHS and have been pushing HHS to get information out to define what's considered an essential visit versus a non-essential visit, and allowing agencies to make what's called non-essential visits through either through telehealth to include telephonic communications. We don't have that in writing as of yet, but again, that is something that we hope to see in these emergency rules and in some of the policy guidance that HHS will put out for agencies for regulatory relief. So that's also very important. You had mentioned some constraints in getting into facilities. We, as soon as we started hearing about that, both on the hospice side and on the ALF side, we reached out to HHS. They did put out written guidance to these facilities saying that home care agencies were considered essential personnel. However, they do require those facilities to go through a screening process, even for essential personnel. So that means that you, as a home care worker that might be seeing a patient in an assisted facility or in a nursing facility for hospice or some level of home care, will have to go through a screening process to kind of get in the door. So they should not be barring you from coming into that facility, but they should be going through a screening process with the healthcare worker to ensure that they are asymptomatic or not showing symptoms of COVID-19. And likewise, you should be doing the same thing, as I mentioned, following the guidance issued by our Texas Department of State Health Services, and making those phone calls ahead of time to your patients, asking them those questions. Has the patient themselves or anybody that's also in the household experienced any particular symptoms, be it a cough, congestion, or fever, and going through that screening process before you send individuals out to the home. And you also mentioned, Tammy, the shortage of supplies. We have been in contact with DSHS on a regular basis about the shortage of supplies. We do realize and have elevated the critical need for home care agencies to have access to supplies. Agencies are encouraged to be judicious with their PPE. For instance, use of N95 respirators, for instance, or masks, for instance, is not called for with every single case. It is not something that agencies should be using going into homes where they've done the appropriate screening and there's no one in the home that has any presumptive positive or any symptoms. So it is important to be judicious with your supplies. There is a process in place right now. We are, as a matter of fact, I had some conversation with the state office again today. They're updating again their guidance for healthcare providers and obtaining those supplies. Right now, the guidance is if you are critically short or in need of supplies, PPE in particular, and you have gone through your normal process, that you need to reach out to your local EMO, which is your emergency management office, to fill out the SARS application to get supplies allocated through the national stockpile. That is difficult because there is a worldwide shortage of PPE. So I know it's very frustrating for agencies right now. We are in contact with DSHS every single day, trying to get the most direct process for obtaining those supplies.
Thank you, Rachel, and thank you for giving us a way to contact people if we don't have supplies. I was also going to ask you about ALFs and memory cares, and so far still not allowing home health agencies in. I was in contact with a pretty large multi-state agency that is still experiencing that, non-essential staff, they're only considering that wound care. Where would they report that to? Where would they go with that in order to get access to some of these facilities?
We are putting that on our website, and we've actually put that out on our open forum. So I'd be happy to send kind of a direct link to that after the webinar if that is helpful.
That would be great. Thank you, Rachel. Great information. Axxess is also partnering with our state and national associations. We do have a link on our site as well, which will link you directly up to both the national organizations and TAC, and also World Health Organization, CDC, and we encourage you to utilize that link as well. Okay, kind of switching gears a little bit and kind of going more into the PDGM route. One of the things that Axxess is doing now is developing scorecards for PDGM, where we can actually look at the case mix, we can look at the LUPA thresholds, we can look at how fast that clinician gets out there, so we can identify training opportunities. And we do this through both our Axxess solution and our Axxess Care mobile solution, and have this available so as you're starting to look for staff, you certainly want staff that are highly trained, but you want staff that have a certain clinical profile as well, especially in the pandemic. We think that these scorecards would be very useful for agencies to take a look at prior to hiring additional staff or recruiting additional staff. And truly looking at PPS and PDGM, their skill sets are exactly the same. It's just that they've been magnified under PDGM. Much more than they were prior in PPS. Things are really intensified due to the 30-day payment period. We really had to tighten all of our skill sets and all of our processes. So looking at a case manager, first and foremost, our RN case manager is advocacy for the patient. And I love what Rachel said about, we have to be a true advocate for that patient, and we still have to do what's right for that patient. It's still incumbent upon us as a home health agency to get information from that physician on the face-to-face visit. It's still incumbent upon us to do everything we can to control outcomes. Even if we are being denied access into certain facilities, we have to continue to be that patient advocate. More than ever now, communication is huge. We have to communicate 3, 4, 5 times over in multiple different ways. We utilize secure messaging throughout our Axxess products, so we can communicate with 1, 2, 50, 100 clinicians in the field at the time, all through secure messaging. We have even noticed, the things that you don't know until you're in an actual pandemic. There's limits to some of the communication that's out there, even through Skype and Teams, how many people can actually be on unless you do a certain type of meeting. Within our products, there is no limit. So you're able to communicate throughout your whole organization securely. And being a mobile web-based solution, that communication never goes down. Even if the person is out of range or maybe in a place where there's no cell towers, as soon as they pop back into range, they're going to see that communication. Clinical skills. Clinical skills are huge, especially assessment skills right now. We want people that have strong clinical and assessment skills that are going to be able to not just assess for signs of COVID-19, but assess for underlying conditions and for exacerbations. In a situation where elderly people become isolated, depression is huge. It's already rampant in our population. Now we're adding that even further degree of social isolation, and then the negativity of COVID-19 every time you turn on the news. So it's going to be imperative to us to start looking at the secondary diagnosis and primary diagnosis because we know depression adds to any comorbid diagnosis. Knowledge of home health is huge in hospice, and knowledge of infection control, very important to know about infection control and know how to utilize that in the home. We're not in a sterile environment in a home health and hospice setting. We have to think on our feet, and we have to provide the most infection control precautions that we can, sometimes with limited ways. I can remember going back many, many years ago, and not necessarily infection control, but having to start an IV and there's no poles, there's nothing. So, you make do with a clothes hanger and hanging it over a door frame to provide an IV drip. And I know our nurses are making do with that now. I know, we're grabbing H-E-B, Walmart bags, using those as barriers. There's times that we're not taking our bags into the home. We're putting the supplies we need into our pockets. Certainly hanging our bags when we do take it in on a doorknob. Those are just tips that we have to do and we have to adjust for, because, again, we're not in a hospital. Cultural sensitivity is huge during this time. We have to pay attention to that. We also have to pay attention to how people feel. Just like Rachel said, it's not recommended to go and wear a mask into every patient's home. And how does that make patients feel if we're gloving, gowning, masking up into every patient's home? And certainly if we suspect the virus, we have to do so, but we need to explain that to them. Organization is huge. As in PDGM, we need to know what the goal is prior to going in the home. Kind of gone are the days going in to assess the patient. Every visit has to count. Every encounter has to count. Kind of goes back to the time when I started home care years ago. You knew exactly what your skill was, and you knew exactly what your end goal was. And I think PDGM is circling us right back around to that. Critical thinking, being able to make changes quickly in the home environment, being able to see quickly if we need to change direction and focus on another skill set is important under PDGM, and certainly important under a pandemic. We also have to be extremely flexible and adaptable. You may think that you're seeing 3 patients on the east side of town when actually it all got turned around and now you're seeing 6 patients on the south side of town. We have to be able to flex and adapt to that, and also adapt to changing information. Tons of information coming out now. It's almost information overflow with COVID-19. We have to be able to take that information, simulate that information into our practice very quickly. Attention to details and documentation, certainly important in PDGM. I believe every note has to stand alone. It did in PPS, but even more so in PDGM. I need to be able to see, if I look at that note, what the skill set was and what we accomplished for that patient. And certainly now dealing with PDGM, good infection control technique is a must. We are actually uploading that profile into Axxess Care, as well as a screening tool to see if, make sure that the staff is screened. So when our agencies are looking to supplement their staffing now, they can see that the screening has already been performed for these individuals that are using the Axxess Care platform. And I can't stress enough, obviously no fever, no symptoms of any type of infection. We do not want to take any chances with this population. Looking at our clinicians' turnover, right now it's about 19 months. This is overall, not just home care and hospice. And RN turnover is about 19 months according to the Bureau of Labor Statistics. And that cost of turnover, according to the 2016 National Healthcare Retention and RN Staffing Report, is anywhere from $37,000 to $58,000. So it's incumbent upon us to do what we can to keep our staff in place, and to make sure that we're doing things for our RN staff to want to make them stay in place. Like, for instance, I know of organizations now this may sound crazy, but it is a pandemic, that gave out toilet paper, 6 rolls of toilet paper to all of their staff yesterday. I think you could have gave them a $1,000 bonus and the toilet paper would have meant more to them. That's how important it was. There's home health agencies actually setting up daycares so that the nurses can go to work. So we're seeing a lot of out-of-the-box kind of thinking by our leaders in home care and hospice, and making sure that they actually take care of their primary asset right now, which is their nursing and their clinical staff, their therapy staff as well. Today, we have about 3.8 million registered nurses, and only about 85% of them are practicing nurses. 53% of them are over 50. I don't have the statistics for over 60, but I am hearing that there's a large portion of home care and hospice nurses that are hitting that 60 range, which puts them in a high risk for a pandemic, for COVID-19. So we're starting to see some of these nurses self-eliminate from the workforce during the pandemic. They simply don't want to chance it. So that's causing some of the shortage, is because we do have nurses in that high-risk category. And of these older nurses, we're seeing about 70,000 of them retiring annually by 2020. Rachel, do you want to say anything specific about Texas, what you're seeing with maybe even some of our older nurses, if you have any statistics on that?
In terms of the availability of nurses?
Yeah, that, and are you seeing anything, 60 plus nurses in home care and hospice? I'm not sure you guys carry those statistics, but we're hearing there's quite a big amount of nurses, a large number of nurses in home care and hospice that are 60 and over.
Yes, I think overall, from the overall nursing statistics, we have a lot of nurses that are approaching retirement age, working in the healthcare system as a whole. Just to kind of play off the statistics issue, and something that we're working with it's called the Nursing Workforce Data Advisory Committee. I'm actually also part of that committee, and it looks at nursing workforce. They do what's called a workforce survey. It's called a nursing workforce survey, or they call it a hospital staffing or home care staffing survey. So unfortunately, this last year, home care agencies did not respond to that survey very well. I think it was a function of how that survey was conducted by that state agency. We're working on revising it's called a vacancy survey. It goes by a number of names. And looking at the population of nurses that are available to serve home care and hospice agencies. We're seeing, like I said, a shortage, or an approaching shortage in a number of locations. It's variable. Again, we're seeing that registered nurses are hard to get in the home care part of the world, because many hospitals are going to magnet level certification, and in order to achieve that certification, they have to use primarily registered nurses. So that leaves a lot of LVNs available. However, it makes it challenging for us to staff cases, because you can't fully staff cases with just LVNs, and you have to have RNs in that kind of staffing matrix. So overall, we are working in a proactive way with our state entities that are looking and evaluating this, and developing policy reports to the legislature to address nursing workforce overall.
Excellent, thank you, Rachel. And when I started pulling some things about what causes turnover, documentation comes up over and over and over again, as well as surges in workload. It's usually the surge comes on a Friday afternoon when everybody wants to get home with their family. You start seeing that surge. And then drive time, especially as we start looking at our older nurses, those 60 and over, the drive time becomes a real issue to be in the car 2-3 hours a day. So personal reasons for leaving the workforce, according to the Texas Center for Nurses Workforce Studies, is fatigue, drive time, work-life balance. And a lot of times, guys, when people are telling you, I great organization, I just can't do it any longer. I got to look at spending time with my family. There's things that we're doing on our side, and a lot of that is that documentation and the surges in workload. So direct quotes from some of these nurses, I just kind of went on and pulled this from Glassdoor and several other sites. And this was just within the last week. People are saying paperwork's too lengthy, the orientation's inadequate, the training is poorly structured, workload is equivalent to 2 full-time jobs, advice to management, relief of stress, and better training for employees. These are the things that our nurses are saying once they leave the field. And sometimes when they leave the home care and hospice field, we don't get them back. And certainly now during a pandemic, I think everybody, all of our nursing force, is all hands on deck. Everybody's wanting to help. But again, there's going to be some limitations with people. Maybe they have, maybe they're in a high-risk category because of age and secondary diagnoses. So I think it's very important that we start connecting people, agencies with nursing staff that are willing to pick up and do extra. Certainly nurses are not computers. Sometimes I think technology can impede clinical practice. Sometimes we feel like we're spending too much time on the device and not enough time with the patient. That's one thing we do inside of all of our products, is make sure that our staff are able to spend that face-to-face time, that bedside time with the patient, and much less time in the computer. And we do that through clinical intelligence, making it very easy to document. Productivity, when PDGM came out in May 2019, about a third of the agencies, almost a third, said that they were planning to increase their productivity standards for clinical staff. And that's okay if we cut out something on the other end. So that's where technology has to enhance that care of that patient. And I say technology to promote nurse retention. You have to have ease of use. You have to have interoperability. Systems have to talk to each other. Nurses don't want to enter things 3, 4, 5, 6 times. In addition to that, it's just going to improve outcomes. And then there has to be data to help guide the care within the technology system. And again, all of our tools inside of our product does that. I mentioned clinical intelligence. We call it OASIS real-time validation. So that if you answer a question and you say somewhere that the patient has COPD and you go back and you answer your OASIS, we're not going to let you say that this patient is not short of breath. That's not congruent to each other. The other thing we do is geomapping. If we could spend more time doing patient care and less time driving, so being able to cluster those visits together is very important to productivity. You may be able to pick up an extra patient if you're not driving across town, spending an hour and a half in traffic. Also building in hard stops for clinical assistance. Axxess does that throughout their solutions. We build in hard stops for primary diagnosis. We are completely up to date with all the COVID ICD-9 codes at this point in time. And then we also build in a help center that's not just a written help center, but a video as well. Just short 1 to 3 minute videos that describes everything in our product to be able to make that documentation time less of a burden on clinical staff. Our patient dashboard that's built into our home care product, will identify infections and incidents at a click of a button. If a nurse goes in and she identifies a cough and maybe some signs that will indicate COVID-19 during this pandemic, all she has to do is hit infections here and document that infection control report. And then there's a link automatically that will have her notify that physician. His phone number's there. It's a simple click of a button where she can contact that physician quite quickly. This is huge during the pandemic, but you can see also for PDGM in general, building in incidents, wounds, hospitalizations, everything that that person would need right here at the click of the button, making it very, very easy to drill down. LUPAs, if a LUPA is scheduled under PDGM, maybe inadvertently, instead of scheduling a visit for a Wednesday, we scheduled it for a Thursday, which is creating a scheduling LUPA, which I call avoidable LUPAs. This dashboard is going to notify that nurse pretty quickly so she can make those adjustments. The other thing Axxess does a great job of is the resolving conditions. CMS allows for the second 30 days, because we're in 2 billing periods, it allows the second 30 days if you change your focus, if your diagnosis resolves. Let me give you an example. Let's take the pneumonia patient, comes out of the hospital, and we're really dealing with respiratory and maybe finishing up some PO antibiotics with this patient. This patient's been deconditioned because they've been in the hospital, but we're not ready to start rehab yet. So that first 30 days, we're really focusing on respiratory. By that second 30 days, that pneumonia is completely resolved and we're ready to bring in rehab. This resolving condition or change in focus allows the nurse to quickly change that focus of care, document that for CMS, and write new orders and communicate with the physician with a simple click of a button, all from one page. I think the really beautiful thing about this, it also automatically flows to billing, making it very easy and cutting down that time that the nurse is required to communicate back and forth with operations. So how can technology improve our outcomes? We can certainly, through a predictive analytics, we were looking for those high risk for falls. We're also looking for screening for COVID-19. We're looking for patients that may need to move into the hospice arena. We're also able to perform disease management through pathways and risk stratify patients from the minute they come in. Again, nurses aren't computers. We need tools to help us do this. So if you have a tool that's stratifying your patients and actually saying, hey, based on the way you answered these OASIS questions, this patient's at high risk for falls. You need to put these measures in place. Also having learned behavior in place. There's telehealth and telemonitoring equipment now and sensors in the home that actually learns patients' behavior in the home. So let's say they normally go to the bathroom 3 times and now they're going to the bathroom 12 times a day. These sensors pick that up and it keys you to say, wonder if this patient has a UTI. So things like that, as we're going through a pandemic, it's going to be huge. We have to start thinking in those kind of directions so that we're intervening as symptoms require us to intervene. Also, ease of use. It doesn't matter how many times and how much information is available, unless it's easy to use. Nurses and clinical staff are just not going to assess it. And again, I can't mention enough patient touch points. Every encounter counts. So you may be the nurse going out there to see the patient, and maybe therapy's not scheduled for another 3 days. There's nothing that says that you can't get that patient up and ambulate them and actually help work on a home exercise program with them. So every single touch point of that patient, we have to make count to the best of our ability. So how do we do that at Axxess? I'd like to introduce you to the Uberization of healthcare, where we connect professionals, agencies, and patients. And we do that through our staffing platform. And basically, all of us are used to Uber, where you go on your app and you say, I need someone to pick me up and take me to the airport. And usually within 5 minutes, you have an Uber. Axxess Care is very similar. If you need assistance with staffing, especially during this time of pandemic, you're able to go on and put in a few information like, is this a regular routine visit? Do you need an RN? Do you need an LVN? What is this skill set required by this particular visit, such as a Foley catheter change? Is it wound care? And our platform will automatically match you up to clinicians that have all those skill sets that you need that are in your area. It's huge. Generally, our clinicians reply within about 2 hours for those visits. And so you know that Mr. Smith's going to be able to get his visit today, maybe not by your staff, but by using supplemental staffing through Axxess Care. It's a great way to cover during this pandemic crisis, but it's also a great way to use to grow your business in general, because you're able to target certain areas, you're able to target certain skill sets. Maybe you want to grow an IB program. You don't have your own IB certified nurses. You're able to target that through the use of this platform. The thing I think is very exciting here that Rachel's going to talk about is the legislation that's been released. I'm always have been glad to work in Texas because it's a compact state and I can cross state lines. But there's legislation now that Rachel's going to talk to you about that's changing because of that pandemic. So Rachel, I'll give that over to you.
All righty. And it's actually, it's not necessarily legislation. There's been additional guidance. And so the governor has flexibility to issue guidance as it relates to utilizing nurses in a disaster situation. We've actually posted that on our open forum. Trying to get to our open forum right now, but we just posted that today. That talks about the use of nurses from across state lines. So I'm going to get to that really quick. And that was posted today. So the governor, said to the Texas Board of Nursing, we need to expedite use of individuals from across state lines and put processes in place that allow you to do that quickly and efficiently. So I did post to our open forum today for our members. And again, our members have access to our open forum, and we're using that method of communication to update agencies on a regular basis. As we had mentioned earlier, the situation as it relates to this pandemic is not just changing daily, but it is changing hourly. So as new information comes out, we are ensuring that we post that at least to our open forum so that members know right away what's out there and available. So the Texas Board of Nursing has on their website information about utilization of nurses. So using a nurse that is part of the compact states and has a compact license, there's really not been any particular changes where that is concerned. However, during an emergency, you are able to use any out-of-state nurse with a license in good standing. They're not necessarily required to hold a Texas license in order to practice nursing in a disaster relief effort or operational setting. So they have put that information out there. In addition to putting that out there, you actually can use a nurse with a current disciplinary action on his or her license during a disaster. The process for doing that is also on the Texas Board of Nursing website as well. So in essence, the key takeaways is that you can continue to use nurses across state lines that are part of or that have a compact license. You can also use nurses from across state lines that don't have a compact license, only in a state of emergency and that are in good standing. If you happen to get a nurse that does have a disciplinary action on his or her license, as long as the process is followed in terms of filling out the form, and there is a form that they would have to fill out to get approval for use of that particular nurse. Even those nurses can be used across state lines. So that is posted on our open forum for members.
Oh, excellent, Rachel. And this is huge for us during an emergency crisis, and also for Axxess Care, because we connect nurses throughout multiple states. So if we need to use nurses, say from Alabama to come into Texas, we're able to do that and connect. And there are nurses that are willing to travel. There are nurses that are willing to cross that state line, and Axxess Care can actually connect these nurses together quickly, because I know we're running out of the time. Generally with Axxess Care, these employees' benefits are the staff generally work as 1099 employees, but they can certainly work as direct employees as well. So something to think about. There is a cost savings involved with employee benefits. About 31.7% of a salaried nurse is additional in benefit. So those are cost savings equivalent to about $25,000 a year if you do use 1099 versus direct hire. And this is just a bit of the benefit breakdown here for you. Axxess Care will help you manage your LUPAs, providing, again, you're able to get to those visits. If you miss one visit and cause yourself a LUPA with PDGM, the impact is $1,265 revenue loss. That's a huge loss for you. So being able to prevent those LUPAs with Axxess Care is going to be a tremendous benefit for you. It's also very advantageous to use it for PT visits as well, all therapy visits, because we're starting to see a decrease in therapy visits now. But then we have those surges where we need more therapists. So we're connecting therapists through this app as well. And we're seeing that outcomes are greatly improving because we have the ability to provide these supplemental staffers in the time of need. So some organizations cut down their therapy, full-time therapists, and then maybe they have just a surge or fresh hips, fresh knees, that kind of thing. They don't have enough therapists to scale to that. Our app will help connect you with those therapists so you don't have to turn away those new admissions. Using Axxess Care for business development is huge. I mentioned that earlier. Wound care, IV care is big reimbursements with PDGM. A lot of agencies are starting to look at specialty programs. And again, this app will connect you with multiple clinicians that are credentialed in both of these areas. And then you're able to see that. The other thing you're able to see is how they're rated. We star rate them just like Uber star rates their drivers. So they're rated based on their star ratings, and you can even see comments from other agencies that use these clinical staffers. So Axxess Care Advantage is certainly LUPA, controlling those missed visits, rehab management, program development, decreased costs, as I mentioned, to mitigate potential revenue reduction. It'll help you grow with additional revenue streams. It'll also help you with an OASIS functional scoring. It's going to reduce the turnover because you're not stressing your already stressed staff. And it's certainly now during the pandemic a great way to provide supplemental staffing to advertise very quickly your need for additional staff. So we kind of have the trifecta going on now with the silver tsunami, the nursing shortage, and PDGM. Technology can certainly support and enhance that. And we believe Axxess Care through the Uberization of healthcare is the answer to the staffing issues we're having now during the pandemic. And Rachel, do you have anything else to say to the audience before we close?
No, really appreciate the partnership that we have with Axxess and all of the support that you've given to the home care industry, for sure, and ensuring that the industry has updated and really the latest technology that would help them be efficient and effective in their business, and provide good quality care. I do want to say, and earlier in the presentation, I had mentioned the guidance for healthcare worker entry into nursing homes. That is actually located, it is a public site, so it's available to both members and non-members on our COVID-19 site. It's under the infection control portion. It's related to CMS guidance for infection control in nursing homes. So that guidance is very clear that nursing homes are supposed, not just nursing homes, but facilities in general that are also governed under the nursing home rules. That includes ALFs, to allow healthcare workers in their facilities. And that link will be updated shortly. It has the March 4th guidance, but it has been actually since updated to March 13th. And it shows the updates on that particular guidance, but it is on our website, so it's easily accessible. The other item that I'd like to make sure everybody is aware of is our emergency preparedness webinar that we will be having with Barbara Citarella. You'll have the latest information from an individual who is right in the middle of all of this. She works on several government task force and has been working directly with the COVID-19 task force to review information that CMS is putting out. She understands and knows the latest numbers and what's kind of coming out before it comes out. For instance, I was having a conversation with her a couple of days ago, and she was part of reviewing information that CMS was working on, giving additional flexibility for telehealth and telemedicine. So we will be providing that webinar to folks on the 24th from 12 noon to 1:30. So please go to our website, register for that. I think it's really important to get your questions answered by somebody who is really at the epicenter of a lot of things going on at a national level related to the response to this pandemic. So she will be providing that information. I also spoke earlier about some emergency rules that are coming out as we were on this particular webinar. We received the dates for the webinar that I had spoke about, the possibility with HHS. We will be putting that information out to everyone as well, member or non-member, letting you guys know that there will be 2 different webinars reviewing the emergency rules and some of the written policy guidance that HHS will be putting out for licensed Axxess. So that will be on Friday, i.e. tomorrow. As I said, information's coming quickly and things are changing quickly as well. So we'll have that information out for folks today.
Great, thank you so much, Rachel. We appreciate all of that. And thank you as well, Tammy, for sharing your wisdom and your insight during this challenging and, as we've talked about quite a bit, evolving time for all of us in home healthcare. We will provide everyone with a link to the slides. We're also going to post a video recording of our webinar on our website, axxess.com. So because of our time constraints, we're going to have to wrap up for the day. So thank you so much for joining us as we deliver on our mission to empower healthcare organizations and professionals with the world's best technology solutions. Have a great day.
Thank you for joining our on-demand training today. Axxess is the only home healthcare technology company approved by the American Nurses Credentialing Center to offer continuing education credits and the most recommended home health software on Software Advice. You can watch more on-demand training videos through our industry-leading help center or at axxess.com, where you'll find tutorials, blogs, white papers, and answers to frequently asked questions. Axxess, empowering care anytime, anywhere.